Hello, and welcome to our third Natural Life Transition webinar. As you might know, this is a four-part series, and we really appreciate you taking time to take a step in the right direction to positively manage this life event. My name is Kristen Smith, and I'm the Outreach Coordinator at Oakdale ObGyn. I'm going to be helping to moderate this webinar along with Andy Meyer, our technical consultant. This webinar's topic is ages, stages, symptoms, and treatments. And while it's more clinical than the last two webinars, it's not going to be boring. We're going to cover logistics, if you will, about what's going on with many of you and why. And then we're going to spend most of our time talking about what you can do to tame some of the more interesting aspects of perimenopause and menopause. The handouts are available on our website for download and in the chat box. We're going to post the recording later tonight on our website, on our YouTube channel, and to Facebook. And we invite you to share it with friends and family as well. We know there's going to be a lot of questions, and we're going to save those until the end of the presentation. If you have a question, type it in the Q&A on the bottom of your screen, and we'll work through those at the end. And with that, I'm going to introduce our Oakdale Women's Health Specialist, Dr. Sarah Manneh, and Nurse Practitioner, Bethany Hjelle. Combined, they bring more than 25 plus years of experience to the discussion, and they're well-versed in answering your questions. So with that, I'm going to turn it over to this talented duo.
Hi, I'm Dr. Sarah Manneh. I actually have been with Oakdale for 17 total years, but in practice for 20, going on in 2023. I'm actually going to turn 50 in 2 weeks. So for a lot of my patients who are on right now and who will listen later, 50 will happen in about 2 weeks. I have a daughter who is a sophomore at the University of Southern Cal, and she's living the great LA life. And I am an empty nester. So that's exactly why this talk is very passionate for me. And I want to share the gems and pieces of knowledge that I think everyone will want to hear.
And I'm Bethany Hjelle, so I'm one of the nurse practitioners here. And like Sarah, I feel like this is a topic that is starting to get near and dear to my heart. Because for many of us in our 40s and as we approach 50, these are things that every woman goes through. And so I think I'm 44 and I have 4 kids. My oldest is my son, he's 20 and he is a junior in college. And then I feel like in my household, we still have a lot of raging hormones because I have 3 teenage daughters. So that is a very interesting conversation most days in our house when there's all 4 of us cycling and you've got me who's maybe kind of starting to phase out, but they're ramping up. So anyways, hormones, it's a fun topic. So we hope to keep it lighthearted for you guys, but also hope that you walk away kind of feeling that you are empowered to make some choices or kind of know how to help manage maybe some of the things that you are starting to experience as we start to go through this normal natural life transition.
So here we are, we're going to talk about perimenopause and the menopause, definitely a natural life transition, and excited to move forward on this talk.
We get to move our slides.
So a couple of just very basic things, the actual definition of perimenopause and menopause. Perimenopause is considered really the transitional time. It's what we know to be around menopause, when there are changes in the menstrual cycle and definitely some physical and emotional changes that come with it. It can last a total of 2 to 10 years, on average 5, and typically the landmark of perimenopause is age 45. That's just kind of what we say is where women are going to begin it. In menopause, it's the definition of no periods for 12 months. So someone who hasn't had a period for that time is in the menopause. On average, in the US, what we see for national data is in all women of all races, if you group them all together, the average age is age 51 to 52. The data is strongest in white women in that age range to accomplish menopause. less than 5% will experience it in very young ages, age 40 to 45. And by age 55, 95% of women have undergone the menopause. So again, no period for 12 months. There is an important study that I like to refer to. It's called the SWAN study. It's the study of women, women's health across nations is what it's called, the SWAN study. So in that study, it actually broke down when menopause would occur by race. So by race, Black Americans, Native Americans, Hispanics, those women actually undergo menopause 2 to 3 years before. They undergo menopause at age 49. And then when you take the population of Southeast Asian women, including East Asian, Southeast Asian, Eastern Indian women, those women will undergo menopause later, 1 to 2 years later. So by age 52, 53, they'll undergo menopause. That data in Asian women I find fascinating, right? That's where I am in my ethnicity, but a lot of that comes from having a lot of soy intake and having estrogen-like properties in soy, so they undergo menopause later. When we talk about stages of menopause, there are certain stages of menopause. The stages in menopause end up being where there's an early stage where women in the early 40s are considered, from 40 to 44, undergoing menstrual flow changes. They're undergoing, more heavier flow, longer cycles, definitely as a result from a down production of estrogen. And estrogen,
That's me right now.
That's right. Estrogen is the key player to what's happening in what we're seeing in menstrual flow. The other thing that we see in early stages of menopause is there can be some mood changes, more PMS, definitely fluxes in what you're feeling emotionally. I kind of equate this too as when you think of a teenage young girl who's trying to ramp up her estrogen when she doesn't have much to build. As mid-40s, we're the same. We're matched to teenage girls because our estrogen is down ramping. It's not really ramping up, it's actually down producing. So when you think of your raging hormonal teenager, when her estrogen is unstable, well, we're kind of the same. We're matched at some point. So our PMS symptoms are very similar. So in the late stage of menopause, that is in the very late 40s and early 50s. And that's when estrogen production markedly declines. And in those women, we find that when your menstrual periods start to space, roughly within 6 to 12 months, you'll have full cessation of periods altogether. So 12 months of no periods altogether. And in the significant dropping of estrogen, what we'll see is more symptoms that are significant for vaginal dryness. There'll be more hot flashes called vasomotor symptoms. That may lead up to a total of 5 years, even beyond menopause. So those symptoms can be pretty significant. So how do you know? I mean, for a lot of women, they don't know. For example, and we'll talk about this later, if you've had a hysterectomy, you don't get your periods and the uterus is gone. If you've had a progesterone containing IUD device and you don't get your periods, it's really hard to know. Some markers, 12 months of no periods, but we can do some testing. What I say about hormonal testing is that it's not very useful. It's only useful when you're actually thinking about starting hormone replacement, or you're trying to follow someone's estrogen levels while they're on hormone replacement. So to just say, hey, I want to be tested for a full hormonal panel, or my naturopath or another provider has given me a full hormonal panel, and what do you think of this? For us as providers, it's super confusing and we don't really feel like that's useful. And I think
I agree.
You would agree, right? So, but if we had to test, there are 2 key players to hormone levels that we should test. One is a hormone called follicle stimulating hormone, FSH. That hormone is made in the base of your brain in a gland called the pituitary gland. And what FSH does is it pulses signals to your ovaries to make estrogen to work. And when your ovaries are not making estrogen and they're in the perimenopause and menopausal phase, the FSH levels that are looked at are high. And usually when they're at levels above 20, we're going to say, okay, something's not efficiently working with your ovaries. And then if they're at 30 or above, they're definitely at levels that would indicate menopause. There's one more hormone called anti-Mullerian hormone, or AMH. That is a hormone that is made inherently to the ovaries from eggs, from sacs that hold eggs. And so if you're not ovulating and you're not making eggs, the AMH hormone is going to be super low. So at a level of 10, and I'm not going to give you the units because the units are confusing, but at a level of 10 or lower, the ovaries are done. They're not making eggs. But again, those levels are not useful to us unless we're really putting someone on hormone replacement therapy. Things to think about regarding what you're experiencing, irregular periods, maybe heat intolerance with hot flashes, maybe these mood symptoms, low energy. Well, we have to rule out all the other really important things. So, we need to rule out, do you have a thyroid problem? Is there another autoimmune disorder or metabolic problem that's creating the symptoms that you're having? Because these symptoms can also be very similar to other diseases. So when I do blood work, sometimes I will do, or more universally do, thyroid, because thyroid hormone levels and thyroid problems, low functioning thyroid, high functioning thyroid abnormalities, those are inherently 10 times more common in men or in women than in men. So I'll draw that to rule out a thyroid problem if it's hot flashes or night sweats and heat intolerance and fatigue. I may throw in a complete metabolic panel, maybe looking at electrolytes, making sure that your kidneys are working fine, that also your blood count, you're not fatigued because you're anemic. I'll throw out maybe, and this is stretching it, looking for inflammatory autoimmune responses and looking for something called a C-reactive protein to look at other diseases. But, not in the specialty of OBGYN, but I'll still look for those and refer out if any of those are abnormal. Symptoms, right? How do you know? Well, the symptoms that happen with perimenopause and menopause are truly from the decreased production of estrogen and progesterone. That results in inconsistent ovulation, and from that, inconsistent production of progesterone and estrogen, which all results in hot flashes and night sweats. It results in weight gain, basically due to and I'll talk about this later, where the fat is depositing based on the lack of estrogen and changes in cortisol and changes in insulin sensitivity, and all of that fat deposition is in the low belly. It results in losing lean body mass and muscle mass because of the estrogen, which drives muscle build. So estrogen builds muscle. It's called anabolic muscle building. It will result in fatigue and disrupted sleep, also vaginal dryness, mood changes. It's a multitude of things that women come to us that they're experiencing. So what about family history? Family history is really important. I tell people, do you know the history of what's happening with your oldest sister sibling or your mother? Do you know the ages at which they undergo menopause? Because that is fairly consistent. Yeah. I will say most women fall into that pattern of when their family members have undergone menopause. If your mother had a hysterectomy early, if your sister doesn't know that data, if again, it's unknown, then I would use the national data to say, 51, 52 is pretty average, pretty standard. There are some things that I would say you should look out for. There's something called premature ovarian failure. And in premature ovarian failure, those women actually undergo complete stop of their periods in the mid-40s. So under age 45, their periods just are not there. But that can be from a lot of causes, mostly autoimmune. So there can be things that destroy the production of estrogen within your ovaries itself. You can have, say, a genetic disorder that maybe you're carrying extra portions of a Y chromosome that would make you more male. It could be that you have a medication you're on that's destroying, the way your ovaries are working, that your thyroid's working. And then, of course, there's certain cancer treatments, women who are receiving treatments for breast cancer where they're on anti-estrogen medications to treat that. So, right. So early menopause is definitely an issue. So what are really the most common symptoms? I alluded to those a little bit. I think what we see most is irregular periods. They happen right in the perimenopause. I mean, mid-40s, cycles that start off more heavy and they're frequent and they're spotting in between. And then they get to a point that prior to hitting 12 months of no periods, they really space out. The hot flashes and night sweats, called vasomotor symptoms. It's hard to really explain what estrogen's role is in that, but the link seems to be in how your vascular system, what the triggers are in the systems that open up your sweat glands and that signal heat intolerance. They all are connected, and still the studies on that are fairly questionable. But yeah, feeling hot and feeling sweaty and wanting to tear all your clothes off and flushing. I mean, that's very common. With that, if you're having hot flashes, night sweats, they happen at night. So sleep difficulties, insomnia, not being able to fall asleep, just having sustained sleep is a really big problem.
That's a really big problem.
I alluded to vaginal dryness. We know that estrogen creates more elasticity in the vaginal tissue, in the layers in the vagina, and in that lining. So when there is thinning of that lining, it can be painful to have sex. It can create what we call atrophic vaginitis, where you actually present with what feels to be like a yeast infection or a irritation, chronically itching, chronically intense burning. Of course, it can lead to decreased sex drive, because if you're having pain with sex, you're not going to initiate wanting to have sex. And so that's decreased libido. The mood issues, depression, anxiety, PMS, that is inherent to the experiences, to what we're all experiencing as women. I mean, when we're undergoing so many drastic symptoms, and, you know, that comes with it emotional disconnect with who you are as a person, who you're relating to with your family members and your friends. What I hear from in probably 20 to 30, if not maybe 40% of patients, is weight gain. Weight gain is huge in this age range, and it can occur most commonly 3 to 4 years before menopause actually begins. So in the heart of perimenopause. Here's what we know. I mean, women who are in the menopause, they have a decrease in the way their insulin works. So your body's sensitivity to insulin, this hormone that makes your blood sugars normal and low, that's made by your organ, the pancreas, it doesn't work as well. And somehow estrogen and the decreasing of that creates insulin resistance. Insulin resistance creates a higher risk to diabetes. So blood sugars can be higher, and that's why we can see type 2 diabetes more common in this age range of women. That insulin resistance also creates more fat deposition in body cells. So fat just packs on in places you didn't think would pack on. What we also know is estrogen is a big player in cortisol, the stress hormone. And when your body thinks everything's out of whack and you feel like you're out of whack, your cortisol hormone goes up. And cortisol hormone then creates more body weight deposition, but right here in the mid belly. So more abdominal fat. Remember what I said, when estrogen is creating or should create anabolic growth of your muscles. Well, when estrogen decreases, the muscle gains that you get decrease, and you need muscle to hold on to bone mass. You need muscle to drive your metabolism. And so then, you know, if you don't have muscle, you're going to also gain more weight. So there's a ton of that in the science behind what estrogen and the lack thereof is doing, where you're gaining more weight in those areas. One thing I want to debunk is forgetfulness is not synonymous for menopause. So a lot of women say, I can't think right, my acuity and thought, and kind of, you know, knowing where my keys to my car are, and how did I drive to a place that I know very well, and I don't remember that. Forgetfulness is not synonymous with menopause. It happens, and The best way to prevent it from not happening is always being engaged in mental activities and trying to make sure, you know, you're pushing that. So doing puzzles and, you know, trying to do games and being a hands-on person to help drive your memory. Those are important things for memory, but it's not universal for menopause. Something that I wanted to throw out too is the severity of menopause is actually race dependent.
Yeah.
This was amazing to me, but it's true. Hispanic, Black, and Native American women, they have extreme menopausal symptoms, more so than in Asian Americans and white women. So we don't know why that is, but the intensity of their symptoms can last on average about 9 to 10 years, and in Asian women, 5 years. Like super short.
You're so lucky.
I am lucky. I know. So, you know, I think that's kind of a fascinating thing. I don't know why that would be, but we see that in our patients for sure. Another thing, smoking makes your symptoms worse. So if you smoke a cigarette, if you smoke marijuana, but if you're smoking, the intensity of hot flashes especially are the worst. But if we take all those symptoms, that's what we know to be, you know, the symptoms most commonly associated with menopause. I am going to transition just a little bit about just estrogen, and you'll hear the different types of estrogen. And Kim, in our previous talk, alluded to this. She did our talk on nutrition and wellness and food intake and what that means to you in this phase of life. And she talked about estrogen types. But in our young reproductive life and having children, the most common estrogen type was estradiol, right? So estradiol E2 is what reduces when we're in the menopause. But after menopause, we always are making one other type of estrogen, and that's E1. It's called estrone. And estrone is made from actually fat. It's stored in your body, and fat cells will continue to make estrone. And testosterone, which also is stored in fat, is converted to estrone. So we're making E2 estrone throughout our lives. So this is why it's important to get your weight under control when you're a woman in this phase of life. Body fat holds on to estrone, and estrone, if you still have more estrogen, will make you have hot flashes. It will make you have night sweats. And if you don't lose that weight, your symptoms are more severe. So one other estrogen to talk about, E3 estrogen, estriol, is a hormone we made in pregnancy when we were reproductive. So in younger years, if you were pregnant ever, estriol was the hormone player, but it's not a player in the perimenopause and menopause. So I just wanted to throw that out. Hormone replacement, is it bad? I mean, this is what I say to women. I don't know if you say this, Bethany, but every woman is meant to have a life change where estrogen is no longer made. This is our natural path in life. I don't know why that was evolution, but it is.
It is.
So to replace it is based simply on whether you're debilitated enough to require it. So if you have horrible night flashes, hot flashes and night sweats, that you're not functioning in the day, you're not sleeping, you are not having normal relationships with your partner, your friends, then have hormone replacement. But it has its risk factors and it has its benefits. But you have to accept the fact as women, we will not make estrogen, and that's okay. So do we have to replace it for every single woman? My answer is no, because the natural process of your body is meant to adjust to that over time. But if you need it, I will prescribe it.
Yep,
Bethany will do
absolutely.
it, and we will support you in that. So it's not bad, but I want you to really think about, why is that good for you? And what does that mean as risk factors for you down the road?
And we'll get into some of that more
Yep.
too as we move forward. So.
Yep. So Bethany, we'll talk about now like the treatment of menopause and those options.
So I like to think about that on the previous slide, we don't like to use the word treatment because treatment actually implies that menopause is an illness. And we know that it's not. Just like Sarah was saying, it is a normal life transition, and our bodies were meant, for whatever reason, to stop producing estrogen. And so it is something that every woman goes through. And so we like to view it as options to manage our symptoms, not that we need to treat something. And just like, I think about remember back when we were getting our periods, and again, probably because I'm in that phase, I've got 3 teenage daughters, and I'm even amazed that each one of them kind of experiences something different, right? One of them has really heavy periods. The other one like barely bleeds. And I'm like, wow, you're like genetically related and I gave birth to you and it's very different. But we think about similarly, when you had like your friends, when you got your period, not everybody had like a really awful heavy period. Some people had really irregular periods. Some people had really bad cramps. Some people never had cramps. Pregnancy, some people get really sick during pregnancy. Other people don't. I think it's the same with menopause. And so we think about, it's not a one thing fits everybody. Some people may breeze through menopause without any symptoms, and that's wonderful. Other people may have some of the symptoms that Sarah was just talking about. We think about the hot flashes and the night sweats. We think about the mood changes and kind of feeling, think about like the forgetfulness, but some people will feel like they're in a fog, or they just can't think clearly, or they just don't feel like they can get out of like just like their mental funk for whatever reason. We think about the vaginal dryness, or some people will notice that decrease in libido. But again, some people may have one symptom, other people may have every symptom, and it's so different. And so we want to kind of tailor our approach, just like we do with everything, to just go, here's a variety of options. And we kind of lay it out there. Again, there's not one mode that's better. It kind of is what works for you. I preface as we move to non-medical, and I just say this as my kind of caution, as we talk about like herbal supplements and essential oils. I just will make our disclaimer. None of these have necessarily been FDA approved. Even if you take vitamins or supplements regularly, you'll see that on the bottle. It'll say like not FDA approved to like treat conditions or illnesses. And that is just something that you need to be aware of. However, we know from various literature, as well as from anecdotal, from observation, we do know that supplements and herbs can play a role and do affect our bodies. And one of the things that we are mentioning or talking about here is something called adaptogens. And adaptogens are, by definition, you'll see it, a root, an herb, a plant, but it actually exerts a specific effect on the body. The reason we have to be careful with supplements is because they are adaptogens. They do produce an effect on their body. There's certain supplements or certain herbs that we take that can actually interfere with some medications that we might be on for a chronic health condition. So we really need to be aware, and I think it is important to have a conversation with your doctor, with your provider, if you are taking supplements. And this is my big key when you go in for your annual exams. Please list out the supplements. Tell us what supplements you're on, as well as people just think medications. We want to know that, because sometimes that's important to know what you're doing. Maybe that's something over the counter to kind of know, is that helping? Is it not helping? So do list those out when you come into your visits. But adaptogens, again, they are causing an effect on the body, and most of it is going to be related to kind of an effect on a certain hormone, not necessarily just like estrogen or progesterone, but also Sarah was mentioning some of those other hormones that are at play kind of in this perimenopause, menopause transition. Cortisol, some of these herbs have a specific effect on our cortisol levels, as well as serotonin, dopamine, insulin. And so needing to know that, especially as some of us are on medications for things like diabetes or our thyroid. Ashwagandha is one that basically is going to kind of affect our cortisol level. It does have some moderate benefit in kind of reducing our cortisol level and kind of moderating the stress response. So some people will take ashwagandha for like improving their mood, kind of reducing their stress or anxiety. It can also be used to like increase our libido, or kind of help with our decreased libido, as well as ashwagandha can also help with our metabolism and keeping our blood sugars under control. Sarah mentioned Kim 2 weeks ago gave our talk in this series on nutrition. And so I really encourage you, if you've not had a chance to listen to that, to go back and listen, because she has some great things related to some supplements that you can take, but also kind of the reason that they have the effect that they do on our body. One of the things to be cautious with ashwagandha is that it can also interfere with thyroid medication because again, it's affecting those cortisol levels. And so you would not want to use ashwagandha if you are taking like levothyroxine or Synthroid or some type of thyroid stimulating hormone. We do notice some side effects. Again, nothing, even things that, supplements, vitamins you buy over the counter can have side effects. So some people will notice some GI upset and even a little bit of sleepiness with this. Most of the time you wouldn't want to use this for longer than 6 months, but you will see this in some of the supplements out there. We'll talk about some. I went on a little strolling through like the supplement section of Target. It was really fun. But another one that is commonly used for treating menopause, see, I said the word.
Oh, you did.
For managing our menopause symptoms is black cohosh. And then I want to jump to also rhubarb root, just because rhubarb root and black cohosh have very similar effects. They actually are going to target the estrogen levels. So as Sarah was talking about, our estrogen is kind of taking this, dive down, this supplement can help to reduce hot flashes. And we know that the hot flashes are related to that decrease in estrogen. So you're going to see either black cohosh or rhubarb root in supplements such as estroven, for example. That's a common over-the-counter option that you may see that is targeted for menopausal symptoms to help reduce those night sweats. Black cohosh also has some mild benefits for some sleep issues, as well as, interesting enough, we also know there's some cardiovascular changes that are occurring during this perimenopause, menopause time frame. And some women will notice that it can help with some heart palpitations. So something just to consider. Ginseng, that is one that is going to be an anti-inflammatory. So it tends to boost our energy as well as reduces stress. So you're going to see this in some of our mood boosting supplements that are out there. And it supposedly helps with sexual function, although I think it's maybe because it is supposed to give us a boost of energy and reducing stress. So then maybe we actually feel like our libido is increased because we're less stressed. Maybe, I don't know. Maca is another one, and I don't even know if I'm saying that right. I did listen to Kim's program, but I'm pretty sure it is maca. That is going to also target estrogen, and we see a slight increase in estrogen when somebody is taking maca. It really has very little effect on any progesterone. It can affect your cortisol levels and your thyroid stimulating hormone. So again, we see this when used, it can kind of improve our mood. It can help with hot flashes. We'll claim it helps to increase our libido. Again, same thing, we need to use caution with thyroid medications. It is not recommended if you have high blood pressure because it can cause an increase in our blood pressure as well as some of our liver enzymes. So again, these supplements, I would say they need to be used, they can be used, but we need to use them with caution and kind of making some common sense choices of looking at our other health conditions. And maca is one you don't really want to use for longer than a couple of months either. So here's my little disclaimer. Common over-the-counter options, like I said, estrogen seems to be a very popular one out there, but you're going to see like estrogen complete, estrogen for sleep, estrogen for weight management, estrogen for mood.
It's just estrogen.
It's just, and you're just like, there's a lot out there. And the supplement market, you guys, it is a raging, booming business. And there's nothing wrong with that, but I just say sometimes you can spend a lot of money on supplements, and if they're not working to give you the desired effect, then let's not waste our money. I was laughing because I like going to Target. Do you like like the Ollie brand, the OLLY? I think they have a great marketing person, right? The colors, it's like kind of witty and funny. But so they have one, Love and Libido. That's a supplement. I just found this one. I laughed because I was like, this is gonna be perfect for our topic. The Happy Hoo-Ha supplement. The Happy Hoo-Ha. I just started laughing. I'm like, okay, that's a vaginal probiotic. We may talk about that later, but as well as it's got like Beat the Bloat, Combat Cravings, Miss Mellow. So again, you could be taking like multiple supplements to try and treat each one of these, maybe, manage your symptoms, but just using some caution as you're doing that. Again, sometimes it can be helpful for women, but if it's not helping, I wouldn't go spend a lot of money on it. So, yeah. Other we can think of like non-medical options to manage our symptoms, essential oils. Again, I feel like the essential oils, for a long time, I felt like there's a lot of essential oils on the market and a big push for essential oils. And I actually really like essential oils. I really like the way they smell. I like sometimes rubbing like the little headache relief if I'm having like a tension headache. And we know that some essential oils can help, but I also tell people you really want to do like a skin test if you're going to put it on your skin, because some can cause like an allergic reaction. And some people actually can get a little nauseated from certain essential oils. So you just really want to monitor that. Couple essential oils out there to help with hot flashes. Clary sage is one. Peppermint, basil, interesting, like a basil essential oil. If you dilute it in like a carrier oil and you rub it on your feet or your back, that can help to decrease the hot flashes or night sweats. We think about stress relief. Everybody thinks to be like into lavender. Geranium also helps with stress relief. Insomnia, again, lavender is a big one out there. I think, unfortunately, I have kind of burned through lavender too much, and now it just not smell like, it kind of makes me a little ill. I'm not going to lie. At the hospital where Sarah they have, for a long time, they had some essential oil patches that people would use. So this is treatment, like hospitals will use it. They would use the lavender to help with sleep or anxiety for patients. We had like a peppermint patch. Yeah.
We did.
And the lavender patch, I think a lot of our patients, especially in like labor and delivery, really like the kind of calming, trying to help with the anxiety. And I don't know if I just got overkill. Anyways, I can't do lavender anymore. But so those are, we think about essential oils, other things to help with our menopause symptoms. Sometimes with that mood boost, citrus, like a citrus oil can help to kind of give that quick, like kind of mental clarity. Everybody's starting to talk about CBD oil. There's not a lot of great studies yet on CBD oil as it specifically relates to menopausal symptoms. Most studies have been done in animals. I just put that out there just so you know. But we have seen out of the studies that have been done, some people find some mild benefit with help with insomnia, joint pain, or mood kind of concerns, which all of those things are potential symptoms of menopause. So certainly, if you wanted to use CBD oil, again, kind of I use it at that same caution as with herbal supplements or essential oils. Some other non-medical options out there, cognitive behavioral therapy. So seeing a therapist, in my personal opinion, all of us well-functioning adults should have a therapist in our life.
100%.
And there's no shame in that, right? Never. I think just kind of as we are understanding what's going on with our bodies, but it also means that there's a lot of other transitions that are happening. You talk about now you're an empty nester. I'm talking about having teenagers. And for some of us, maybe our relationships have changed. I have a lot of patients in their 40s that maybe are undergoing a divorce. And so there's a lot of changes happening, not only in our bodies with our hormone levels changing, but also in our personal lives. Some people are in a career change, or maybe all their kids are graduating. Now they're like, what am I doing? What do I want to do for this next half of my life, or this next phase of my life? So certainly seeing a therapist, kind of doing some of that cognitive behavioral therapy, meditation before we go to bed, kind of some guided meditation to help with insomnia, mindfulness training. Again, even mindfulness training has shown some mild benefits with reducing hot flashes and night sweats. Other non-medical options, again, I really push Kim's talk again. She's super helpful talking about certain foods to watch. We know that, for example, alcohol, even though I like my glass of red wine, we also know that alcohol can disrupt our sleep. It can make us sleepy, but then sometimes we can have frequent waking in the middle of the night. We think about some foods to avoid that make menopause symptoms worse. For example, spicy foods, fatty foods that can make our night sweats, our hot flashes a lot worse, as well as caffeine, just processed foods. So trying to avoid that. We also know that trying to shift our diet to maybe more of like a Mediterranean diet is important, especially as we're trying to maybe watch our weight or lose weight during this period of time. Kim really talks about that caloric deficit, and that there's not necessarily one diet that's better than the others, but really kind of needing to know the pitfalls to watch for in each one. Other things that we find helpful that don't have to do with medication are sleeping environment. So making sure that sometimes sleeping with a fan on, having the window open, dressing in light clothing when we are sleeping, during the day, dressing in layers so you can easily take off your sweater if all of a sudden you start having a hot flash. Moisture wicking clothing can be helpful as well. So just kind of trying to manage some of these other like I said, some of these symptoms with non-medication options. There's a lot out there.
I just actually had this discussion with a patient of mine who was having trouble falling asleep, and I was told about the benefits of a weighted blanket, a weighted blanket that actually weighs 12, 15, 20 pounds. And for women who struggle to try to fall asleep and sustain sleep, the weighted blanket, and it's used in chiropractic care and massage therapy, it really just settles on your body and keeps pressure but light on muscles to help them relax. So women who have leg spasms, they're just restless, it works amazing. And I will tell you, I just bought one for myself and I absolutely love it. So 15 pounds sit on me and I've gotten the best rested sleep. So just for sleep environments, that's kind of a nice thing. So we're going to switch gears. We're going to talk about medical options for hormone therapy. This is kind of the crux of what women are thinking about when they're saying, I need hormones, I need a hormone replacement. So why would we use estrogen? Again, going back to estrogen, and the use of it is really to treat symptoms that are so debilitating that you are not functioning in your work world, in your personal world, in any of your relationships. So the best way to put estrogen back in today, and all of the studies that we know, is estrogen replacement transdermal. So a patch that sticks onto your skin. And in estrogen replacement, we know that patch, estradiol, most commonly being used, is going to reduce your risk of common potential complications for estrogen, which is blood clots in your legs called deep venous thrombus that can lead fatally up into your lungs, that lead to pulmonary emboli. Those are fatal. Estrogen itself can put you at risk for stroke and heart attack, and cancers that can impact your breasts and your uterus. So estrogen alone in transdermal form rather than oral form is better received metabolically. It's broken down better, and it doesn't have the same, what we call first pass mechanism through your liver than an oral form. So when I start estrogen, it's estradiol replacement. And then we have to use progesterone in women when they have a uterus. And what is progesterone's role? When women have a uterus, we need to make sure that estrogen does not stimulate growth of the menstrual lining of the uterus. If estrogen is used unopposed without progesterone in a woman who has a uterus, the risk is that the menstrual lining that shouldn't bleed and give you periods grows back and it bleeds. So when estrogen grows your lining back, it can put yourself at risk for a uterine cancer when we're growing the uterine lining when it shouldn't be growing anymore. So women who haven't had hysterectomies, they need both. They need estrogen and progesterone. The way we can give them is we can give combo patches with estrogen and progesterone built into the patch. We can give estrogen in a patch and then cycle progesterone monthly every 10 days. And then we can cycle progesterone into a cycle pattern of every 3 months and give progesterone. But really the effects of hot flashes, night sweats, maybe mood, the stability of your symptoms comes from estrogen. It's not going to come that much from progesterone. It's really the prevention of the uterine lining from growing on that. So, that's really why we would give it. Who are the women who shouldn't take estrogen replacement or progesterone replacement? It's the women that have known breast cancer that is hormone responsive, women who have known uterine cancers, women who are morbidly obese, who are smokers, who are at 10 times higher risk for having stroke and a heart attack. Women, again, who have those already established medical problems. They've had a stroke, they've had blood clots, they've definitely are ones that we don't want to start this on. So, again, am I opposed to giving estrogen? Absolutely not. If a woman walks in and says, I've done my research, I want estrogen, I'll educate her, I'll tell her why a transdermal method is better. There are many ways to give estrogen and progesterone, and Bethany will allude to maybe this later, but it can come in lotion, it can come in skin pellets, it can come in ways that are not FDA approved. But the FDA approved, the well-studied data and literature comes from transdermal patches.
And I also think we talk about with hormone replacement therapy, we really want to just see some people like, how long would I need to be on hormones? And really, we try to keep you on hormones for the shortest time possible that's going to help manage your concerns and your symptoms. And so a lot of times it's not meant to stay on it indefinitely.
No.
One patient came in and I was like, I don't know why we've been on it. I saw her for the first time,
Right.
like, why have we been on this for 15 years?
Right.
When she was 65, had gone through menopause at a normal time. And I just think a previous provider was just like, she's like, I just thought I needed to constantly stay on that. And that's not necessarily the case.
The studies will say put a woman on it for potentially 5 years
Mhm.
max, reassess, and then start to wean her off and take her off down to nothing over time. But I do give a 5-year limit in women who had hysterectomies and had their ovaries removed, and they had it in their 40s, may go longer. So, when I think of someone who at 52 technically should be done with having periods, I'll assess 5 years out from that, like by age 57, surely by age 60, we should be thinking about weaning and being off.
There are some other medications that we can use for kind of as a adjunct or as an alternative to hormone replacement to help manage the symptoms, and specifically hot flashes and night sweats. So this would be a good option for people who cannot have hormones, who can't have the estrogen, our patients who have had breast cancer before, and maybe they've tried the supplements and it just doesn't help them, or they've tried some of the non-medical options. One kind of category of drug class is something called SSRI or SNRIs, and those are typically used for treating depression and anxiety. But there are a couple out there that are commonly used for the treatment of hot flashes, Effexor, Celexa, Lexapro, as well as Paxil. Now, Paxil is the only one that actually has been FDA approved to help treat, there we go, I did say treat.
Yeah.
Hot flashes. However, the others, it would just be an off-label use, but we do see some modest benefit in reducing hot flashes for those women who maybe cannot use hormone replacement therapy. And if you've been on medications like Lexapro or Paxil or Effexor in the past, you know that we always kind of give you the thing that it can take several weeks to notice a benefit. We notice when we are using it to manage hot flashes that we have a faster clinical response than when we're using it to manage our depression. And I also should mention too, sometimes with some of these off-label medications, there is a little bit of a placebo effect. And I think that can be some of the case with a supplement as well, that knowing that we're taking something, whether or not it truly is, statistically or clinically significant in reducing our symptoms, or if it's just the idea that we're taking something and so then we feel better because we're taking something. And that's a real factor. Placebo effect is a real factor. Gabapentin is another medication out there that is an anti-epileptic, so use it for to treat seizure disorders, but it also is used to treat nerve pain and can help to reduce hot flashes as well. It can have a little bit of a sedating effect, so sometimes if you are just needing it to help with night sweats, you would just take it in the evening. But again, sometimes if you're also having the hot flashes, you kind of do a divided dose. Clonidine really isn't used that much anymore, just because it used to be more common in a patch form, but it does have a lot of side effects, dry mouth, dizziness, constipation. So we don't see that one used as much to help with the hot flashes. Sarah alluded to this, bioidentical formulas. Okay, so we have seen this. What exactly are bioidentical hormones? The term bioidentical means that the hormones in the product are chemically identical to those that your body produce. Okay. In fact, the hormones in bioidentical medications may not actually be any different from the ones in traditional hormone therapy, which some people don't know that, but that is the fact. And the term natural means that the hormones are kind of in the product are coming from plant or animal sources, that they're not made or manufactured in a lab. However, many of those products, so many of those ingredients still need to be commercially processed to be bioidentical. And it's a little bit of a misnomer to say that traditional hormone therapy that is approved by the FDA, some of them actually include natural hormones. So certain approved products such as like estrase, Allura, other products that contain estrogens, as well as Prometrium, which has a natural progesterone, all technically are coming from plant or animal sources. They're not necessarily being manufactured in a lab. There can be some advantages over traditional hormone therapy in the sense that they are produced in doses and forms that differ from FDA approved products. And so there may be a small amount of women that could benefit from like a non-standard dose or form of the hormone, like we talked about pellets. However, there really actually isn't any current scientific support to say that there's an advantage over these bioidentical hormones versus ones that are already FDA approved, the traditional formulas that are out there. Bioidentical can be a little bit spendy. They're custom made for you. And so they're based on a test of your saliva to assess your hormonal needs. But unfortunately, you guys, the hormone levels in your saliva don't necessarily reflect the hormone levels in your blood that correspond to menopausal symptoms. So most of these bioidentical hormones are made in a compounding pharmacy as well. Some compounding pharmacies go through very strict protocol and procedure like a regular pharmacy, especially if they're connected to a regular typical pharmacy, but other compounding pharmacies don't have to go through the same like rigorous quality assurance purposes. So I just, again, use caution. I would talk to one of us to see, like, would you benefit? Have you tried the traditional kind of hormone replacement therapy, and maybe you found that the dosing doesn't work for you, or the form isn't helpful? And I would say having that conversation before maybe spending a lot of money on bioidentical hormones. Again, not necessarily bad. I just don't think there's I don't see like this overwhelming benefit to outweigh potentially the cost. And like I said, the risk that it isn't necessarily regulated by the FDA. So
Agreed. We're going to switch to lifestyle and what benefits there are in that and treating your symptoms. I'm a big lover of exercise. I've been consistent, and it's hard to get your mind really into it to drive your motivation to do it. But what I talked about was the key thing about building muscle. When you lose estrogen, you don't have that ability to sustain your muscle mass. And overall, in time, 10% of your muscle mass disappears from mid-30s until you hit menopause. So 10% is a big number. It's actually larger for men. So the benefits of building muscle also will treat your risk of decreasing diabetes, and to, again, create tone underneath skin, and to not have the deposition of fat that's in your mid-belly. So how do you do that? I mean, you have to just find a program that works for you, be motivated by a trainer, maybe a personal trainer, a gym that you like, a community that you like. But even using weights that are as small as 2 pounds, as far as 15 pounds, and doing very minimal time with them. You could do less repetition, under 12 repetitions of bicep curls, and get some tone and muscle mass building. So lower weights, higher repetition is going to give you muscle mass tone. Higher weight in pounds with lower repetition will give you more mass. But things like total body strengthening, resistance bands, when I say total body strengthening, using your quadriceps and doing repeat squats, doing ab workouts, trying to do that to sustain the muscle underneath your skin and to create tone. My cardio now, and women love their cardio. I always laugh about this. We all went through phases of being a runner in our 30s and doing marathons, and now our 40s, our joints and our hips hurt. And so you transition, but cardio in long amounts in this age range will not do it for you. It could hurt you because your joints are fragile, and your knees and your hips have been used a lot. So to really use burst cardio in sessions that incorporate, say, 40 seconds on of cardio, 20 seconds of rest all throughout your 50-minute workout, that's probably the better long-term sustaining exercise. So I'm about that. Yoga, Pilates, those that don't typically build muscle mass, but do build tone. You want to use that, but adding weight and increasing resistance will help create muscle mass. And again, that just changes what I talked about before, and how your body is burning the calories it takes to have muscle, and how that fuels your body for the rest of the day and gives you energy and decreases the amount of calories that you're taking in, because muscle needs more calorie burn than fat. So when we talk about multimodal therapy, I mean, acupuncture and massage, I mean, those are really key things that we can use to help us de-stress and to get through the normal aches and pains and stresses that are happening with menopause. We talked about girlfriends and how girlfriends completely fulfill my need to talk about all my symptoms, but as Bethany had said, not every girlfriend is experiencing what you're experiencing. It's like a different shoe for every girlfriend. It's a different, symptom that they're experiencing, and realize that your family and your support system, your partner in life, whoever that may be, hopefully can be supportive of that.
And we also talk about the fact that we need to talk about it. And one of the most important things in this transition of our life, or this time of our life, is that a lot of people don't talk about sex. So we're going to talk about sex, and kind of go through what does this look like in this time period, or what are some things that we struggle with and deal with.
So we talked about how decreased estrogen creates less elasticity in the vaginal layers of tissue, which creates more pain and vaginal dryness. So that's a key thing for most women. When I say, what do we do for vaginal dryness? It's really to find a really good lubricant. There's many brands. I mean, I'm going to tout a brand and I love it. It's called Uberlube. It's a crazy name, but that brand has pH balance. It's definitely well made to being used in water with toys. It's oil-free, scent-free. It's, stainless, like it's amazing. But to have that be an issue and to combat that with a good lubricant is fantastic. The decreased libido is hard. It's about to your personal relationship with your partner. If you're not connecting with your partner today, it will not be satisfying sex.
Right.
So if your partner cannot pleasure you, and it's all about pleasuring that person first and not you, the libido and drive for you is not going to be there. So there's multiple facets in libido. It's not just because you're in menopause and you don't want it. It's really many factors.
And we want to know too, because it's important if maybe you're, like to Sarah's point, if your decreased libido is because you're having vaginal dryness and pain, like let's talk about it, come in, let's treat. But sometimes we can still get vaginal infections, bacterial vaginosis, yeast, that we want to treat that, because that might be what's causing your pain or your dryness, or why you're not wanting to maybe have sex. I have had now recently, a lot of people want to know, is there such a thing as female Viagra? I wish. I don't know.
No.
So there are two products out there, you guys, because if you've thought about this in your head, and maybe this is like a question that's already popped up on the forum, I don't know, but there are two medications out there that have been targeted towards trying to help with what we call hypoactive sexual desire disorder. HP is a very fancy word, HSDD, but they come with a lot of issues. So one is something called ADDY, ADDYI. It does come with a black box warning. You cannot take alcohol when you are taking it, and it is something that you need to take daily. And you can only use it if you are premenopausal. It's not approved for use in menopausal women, and really only if you have this hypoactive sexual desire disorder. And again, the idea of taking a pill every day for some maybe slight benefit, I don't know. I'm not always a big fan of it. I kind of would think about what are some other things that we can do, because there are a lot of side effects. Again, you can't have a nice glass of wine. It has a lot of GI upset. It can cause sleepiness, dizziness. And again, you can't use it if you are already in menopause. And it can be expensive. I just saw on their website, I was like, ooh, like if your insurance doesn't cover it, which I would tell you most insurances don't cover it, it can cost up to like $99 a month. That's a lot. Okay, here's my thing on that. And then Vyleesi, here's the other one. This is an injection that you give yourself 45 minutes before anticipated sexual encounter.
Well, right. It's not planned, right?
Right. So, okay. So you got to plan for it, which I always talk about. Actually, that's one of the things that can be helpful is like scheduling, like putting it on the calendar, scheduling sex, because you start to think about it more. You kind of put it on the calendar, put it on like your date night. But again, this Vyleesi is an injection you can give yourself. So then we have to, those people who have needle phobias, this is definitely not a good option for you. You cannot take it if you are still getting your period. You cannot take it if you are not using effective contraception, because there is a risk of fetal harm if you were to take it and get pregnant. And it has a little bit better benefit, I think, of increasing kind of your sexual experience. However, part of it is you can't take it if you have high blood pressure, because it can cause an increase in your blood pressure, probably because of the mechanism of action. Or if you have some cardiovascular issues, it can cause changes in your heart rate. And 40% of women experience nausea.
Interesting.
I mean, so really, I don't know, like, to me, I was just like that. I wish there was a better female Viagra out there, but there really isn't.
No.
So there are some other medications, like some people will use, it's an off-label use, something called Wellbutrin, or which is a medication that can help with our anxiety and depression, but an off-label use is also to help increase our libido. But again, there's not a lot necessarily from a treatment of decreased libido that's at least FDA approved at this point, that I'd have a really long conversation. If you wanted to come in and if you really wanted to try one of these medications, we just have a long conversation. I'm not opposed to it, but I just think they do come with a lot of side effects and some risks. So
I'll a little bit allude to being creative, and we put this in as a one-liner, but you should talk to a provider who's really open to talk about what you're experiencing with sex. And when patients come to me and say, it's not working, I'm having pain, my partner doesn't get me, a lot of that can come from just trying to meet with maybe a specialist in psychotherapy that does sexual counseling, but also just the discussion with your partner about what you want, what you need, what positions work, like sexual positions, and asking that about what's good for you to an OBGYN provider is appropriate. Like I answer many of those questions about what do you think about this with these toys and this position. So just find a provider who can talk about that with you. I'll talk about STD screening, because remember, this is the era in which women are having life change, including partner change. Partner change meaning maybe divorce, maybe new partners, multiple partners, experiencing dating again. But STD screening is important. Women in this age range, there's actually a peak for gonorrhea and chlamydia and STDs, because women in this age range think they don't need protection, and they don't need to prevent
they think it's just like if they're a teenager in their 20s,
right, from having pregnancy. So they don't use a condom, and when they don't use a condom, they're going to get STDs. So it's not just about pregnancy prevention, it's about STD prevention, and you should use a condom. The oldest woman I've ever had pregnant, age 53. So you still need to protect yourself against pregnancy, and having pregnancies this late in your life is not risk-free. It can create genetic abnormalities in your babies. And so pregnancy and STD prevention for sure. Contraception, right. I mean, we talked about that. There are many ways to contracept until we get to the menopause. Birth control pills are not ideal because they can change the way your cardiovascular and heart risks are, your blood clotting risks are. So I tend to counsel women on long-acting reversible contraceptives like IUDs and inner implant arm implants called Nexplanon. Those are good ways to go, but I don't want, and we shouldn't start pills on women in this age range. Right. It's a little risky. So we have a grab bag topic, and then we'll finish up here, but annual exams.
Like annual exams. One of the questions that I always joke with is that people, I think if we could do like an education session on that, pap smears are not pelvic exams, or pelvic exams don't necessarily equate having a pap smear. But we want to see you guys every year. I know sometimes when we are in this phase of our life, we kind of put our health needs to the side, but it is important to come in. Pap smears usually at this point in our 40s. If we don't have a strong history of abnormal pap smears, we don't need to collect cells off the cervix for literally 5 years. However, we still want to do pelvic exams. So there's a difference. We can do a pelvic exam, but not collect cells off the cervix. Again, to make sure that that everything is functioning healthy, it looks visually normal. We talk about breast health. A lot of times, a lot of our patients see us as their primary care provider. And so we can kind of be that first line defense for your screening for your cholesterol and diabetes and thyroid. And then if there's concerns, we'd refer you on, but we definitely want to see you for your annual exams. because I think that's important.
Yeah, looking at the vulva, examining skin, going vaginally with the speculum, those I tell women should happen for as long as they can have exams until they pass away. It's important to look at that anatomy, and many other providers outside of us, an internal medicine provider,
They don't look.
family practice provider, sometimes they don't look. So complications, I talked about this about menopause, abnormal bleeding. I mean, that is an irregular periods, heavy periods. That's a talk all in itself. And Oakdale has done many a talk on heavy periods, but do come to us to talk about options, because you do not have to put up with your irregular periods, the ones that are heavy, the ones that you're missing, the ones that prevent you from going out with your family and having vacations and enjoying your life moments. We can help you with that. There are many options to treat you for that. So come and see us. In terms of say prolapse, incontinence, bladder issues, vaginal drop and bladder drop, those are real problems. And that doesn't happen to everybody. I'd say about 10 to 15% of women in this age range are going to have that as an issue, but we can help with help you with that. We have specialists in our clinic that can help with non-surgical techniques and surgical techniques on that.
And I know we're running out of time because we could probably talk all day. I will put in a plug next week. We have someone coming in that's actually going to do a whole thing on mental health, kind of in this perimenopause, menopause timeframe. So I encourage you to tune in next week as well. But we'll kind of leave it. I know Kristen's kind of been monitoring for us as far as questions. What do you got for us, Kristen? I think we can't.
I don't think we have video or audio on you. Still not.
All right.
There we go.
So there, and this is, I think that this participant has a good point. She says, reminder that not everyone is heterosexual and or has the kind of sex that leads to pregnancy. Would appreciate an acknowledgement of that. And I think that's the point we're all talking.
Yes.
So
I would just say that I definitely did not want to put out this to be heterosexual heavy. I have many patients who are same-sex partnered who come to me with many of the same issues, and Bethany as well. I mean, we talk about it in the full gamut and aspects of what they desire and want in their lives.
Okay, so I'm going to start at the top here. Do later pregnancies into early 40s impact the timing of menopause?
You know, it actually doesn't. It's really the timing of when your first period started. So if you're an early bloomer, first period, like within age 10, you're likely going to have menopause earlier. So how many pregnancies you've had in your lifetime, if you've had later pregnancies in life, it's really about whether you had your very first period early, that would maybe lead to an earlier time to when menopause began.
Okay. Here's two questions that are related. One, after menopause, 12 months without a period, how common is it to have another period after that? And related, if you've had 12 consecutive months of no periods and then several months or years later you start bleeding again, is that normal or is it something to be concerned about? And I have a friend that's actually going through that right now.
So that is something that we talk about. Post-menopausal bleeding is always something that you want to come in and be evaluated for. It doesn't always have to be like pathological or something, but it is something that we want you to come in and be evaluated for. Typically, I know if somebody came in, it would usually be looking at, were there any new medications? Were there any cessation of medications that can cause that, as well as, usually want to do an ultrasound of, pelvic ultrasound and what's called an endometrial biopsy, just to make sure that there's nothing concerning going on.
Right. So an endometrial biopsy is where we sample the menstrual lining by using a very thin suction biopsy device. It does create intense cramping. For a lot of women, it's tolerable, but for some women, it can be intensely painful, but very brief. So what I'm doing is pulling small pieces of menstrual tissue, endometrial lining, from the uterus to sample it and test it for cancers. So when we think of a group of women postmenopausal bleeding, they've had 12 months of no period, there's probably only 5, for sure under 10% of those women, if we worked them up for cancer, that actually have uterine cancer. That's our biggest concern when women present abnormal bleeding. There's a component of women who actually will have predisposing biopsies that lead up to cancer, something called endometrial hyperplasia, either with or without atypia. Those are technical terms for the pathologist, but you don't have to have cancer in those biopsies, but they can lead up to cancer. So that is the mainstay of evaluation in someone who has a period after menopause. But remember, when I say only 10%, the other are having bleeding because they could have, say, a structure within the uterus, like a polyp that's disattached and that's bleeding. You could have a cervical growth or lesion that's creating postmenopausal bleeding. Women we think that they're menopausal, but they throw out what I say a last hurrah period after doing the workup, the ultrasound, the biopsy, it's negative. The patient only has 1 or 2 isolated episodes and then she's done. That to me is the last hurrah. Yeah. Right. So
but we want you to come in and
we always want you to come in
because we want to rule out the big scary thing, right? That's no fun.
Yeah, exactly.
Can you have night sweats in the morning or is it only at night?
Oh, you can have night sweats in the morning. Absolutely. The term night sweats is it's an old school term. We really just term it as heat intolerance. So in this talk, just to make it easier, it's heat intolerance really at any time of the day.
Right. Any tips or hints to recognize symptoms and stages for women that currently have an IUD and have had for many years, 15 to 20 years, with IUD already very infrequent periods?
That's hard, but some women, I find this about IUD users, and I am one myself. I've had an IUD subsequently over 4 placements. I had an IUD, a Mirena, when I was 38 and experiencing menstrual changes. I find those women who have IUDs, they actually transition a little better because their periods aren't the consistent focus of their menopausal symptoms, and they're able to function through exercise and activity without their periods better, and hence all the other things are better in their symptoms. But to acknowledge whether you're in menopause is hard. Some women don't have symptoms at all, and they sail through and they accept that they don't have periods on their IUD. Some women may have mild symptoms. It's just knowing whether the heat intolerance is so bad or sleeping is so bad or mood is difficult that brings them in.
I do think with an IUD in place, to Sarah's point, I feel like with some of our women who are on some type of hormonal contraception can somewhat, in some cases, slide through menopause, maybe with more minimal symptoms. However, I would say the most common I'll see is they feel like they're like, gosh, I know that it's not my IUD because my mood typically has kind of had the IUD for 10 years or whatever it is. And now I'm noticing like some changes to my mood. Or sometimes it can be usually like the heat, like, I don't know why I'm having like a little like heat intolerance. Those are probably the 2 things that I feel like are the most common in my patients who have an ID, that they're like, maybe something's going on. Maybe there's some,
but their symptoms overall are better, especially when you're controlling the periods.
Right. I see a lot of advertisements for Provitalize. Thoughts about this product?
Oh, I will be honest, I am not familiar with that product. I would actually have to pull up my phone and see what is on this
list.
But if it has generic off-label, over-the-counter, probably herbal potentials that we've talked about, it probably is safe.
Yeah. And I would say kind of looking at, if you kind of look at the back of the label, because I'd have to do the same thing to see like what's actually all in it. But again, a lot of the things that you're going to see would be some of the herbal supplements that we talked about, if it's targeted to try and treat or manage menopause symptoms.
Right. Is hair loss a common symptom of menopause? And what about facial hair growth? Are these symptoms something to be concerned about?
Yeah, so interesting that you say this. Women who have hair growth, if there's more fat deposition, remember I had mentioned there's testosterone in fat, and that converts over to estrogen and estrone, that estrogen. Testosterone in fat, the heavier that you are, creates facial hair and acne. And so that is an issue that some women see if they're heavier. Even in lighter women, we may see a change in the coarseness of their hair. It may be more darker, stiffer. And that's something that I don't want to say is easy because it's easy to treat, but it creates anxiety for most women. But, a good esthetician and using facial techniques to pull hair off, laser therapies, that really helps. Hair loss, however, I would say is a very common thing, but I don't think that that's a universal thing for menopause. I think that's what we're seeing in just the quality of skin and hair that just happens with age. Hair is more brittle. A collagen and elastin that
Like you'll see
decreases
that.
over time, which creates hair growth. That isn't just about menopause, it's just about age.
And I would say though, with hair loss, there are other medical conditions. I think of like hypothyroid that can cause hair loss. So if you're like, gosh, I'm not sure, I still am having pretty regular periods. If you haven't come in for like a workup and evaluation, because there's other things that can cause that are more, I would say more common to cause hair loss, especially if we're not quite in like that menopause aging transition.
Yep.
Okay. One last question here. Is it normal to experience an ammonia smelling discharge during menopause?
Well, so I talked about atrophic vaginitis when estrogen decreases and it creates thinning of the vaginal lining. That can set up a pH balance change. When there's a pH balance change in the vagina, and the vagina is an environment that's an acid environment. If we go back to science, the pH of an acidic environment is a pH under 7 or near 7 or less. The atrophic vaginitis creates a basic environment. And when the vagina becomes a pH above 7, we have infections like bacterial vaginosis that's caused by Gardnerella, this bacteria. We can have yeast. So that ammonia, very tart, very sour, maybe fishy odor can come from a vaginitis that you should see your provider for. Also realize diet, alcohol, dehydration, all of that seeps into vaginal tissue, into skin, into perspiration. So it may not be an infection at all. It can just be that you're not hydrated. You ate Brussels sprouts or asparagus or, something that comes into your system.
And we even know sometimes with supplement use, for example, people who start taking more vitamins or supplements, we will notice sometimes that they will notice that maybe their urine has they feel like they have an odor or a smell because our body's excreting maybe more of those supplements that we were actually absorbing. So just something to kind of note, to look at your dietary changes too. But if it's bothersome, I would come in to be evaluated for, like I said, bacterial vaginosis or some type of infection.
We can do simple tests very quick.
We get them back in an hour.
All right, I'm going to wrap it up. We could continue to talk and maybe that's
forever. Yes.
To Bethany's point, Patty Hjelle will be with us next week, and she'll be dealing kind of with some of the more psychosocial concerns of menopause. And if you've joined her on another presentation with her, she's going to be wonderful. And on that note, the two of you have been wonderful and just so much information. So thank you very much. And thank you to everybody who is still with us. So there's still some 90 people hanging around.
That's great.
So that's excellent. So thank you so much, Andy. Thanks so much. I really appreciate it. And take care, everybody. We'll see you next week.
Good night. Thank you.